We're now going to look at the factors from the patient's perspective that determine the difference between a laparoscopic and robotic-assisted laparoscopic radical prostatectomy. In the first half of this presentation, we looked at those factors that are surgical factors and determined why one surgeon would prefer one technique over another. Patient factors generally can be looked at as anaesthetic and positioning, complications, length of stay, outcomes, and cost. In terms of the anaesthetic, one of the most crucial factors is the patient positioning. In a laparoscopic procedure, we position the patient approximately 5 degrees head down. This head down position reduces the blood pressure in the pelvis to help reduce bleeding, and also allows some of the abdominal contents to move away from the area of the surgery. What we do laparoscopically, though, is that we use a retractor up onto the bladder, and we are retracting the bladder throughout the case. This does most of the job that a more severe head down position will do in removing the contents from the pelvis. In robotic surgery, by contrast, the patient's in a very significant head down position. This is also called the Trendelenburg position. And as you can see, there's quite a significant difference between the laparoscopic and robotic approaches. So why? Why do we use such a head down position when we're performing the procedure with the robotic assistance? Well, the bottom line is that it makes the operation easier. By keeping all the fluids out of the pelvis, by keeping the abdominal contents out of the pelvis, we're able to see much better and perform the surgery unencumbered. It also can improve the access of the instruments below the pubis, which is the bone on the front part of the pelvis. The reason that this needs to be at such an angle and to be in this fixed position is that when we bring the cart in robotically, that position cannot be changed during surgery. So we tend to take the maximum we can right at the start of the operation, rather than seeing how we go and then being able to increase the Trendelenburg as needed. 35 degrees tends to be what most people would use. Some people can use a little more depending on their table, and others try to use a little less. And the problems with this is that when you're in a significant head down position, we do see increased brain swelling and eye complications. And the brain swelling occurs because there is a raised intracranial pressure. The blood finds it harder to get out of the head, and in as little as 20 minutes, the intracranial pressure does begin to rise. Strong anti-inflammatory corticosteroid medications can be used intravenously to try and reduce the brain swelling, and also there's a limit to the fluids that can be given. We have seen patients have significant brain swelling locally, and it is well reported in the literature. This can manifest as fitting or neurological deficits. With regards to the eyes can be particularly affected by this position, with a raised intraocular pressure, similar to glaucoma. If you already have glaucoma, then being in this position can lead to blindness. Ocular vein occlusion can occur, where the pressure inside the vein of the eye does not allow the blood to leave the eye, and therefore leading to permanent blindness. Reflux can also affect the eyes. The acid in the stomach can rise through the esophagus, through the lacrimal duct up to the eye, and can cause a corneal erosion. This can be counteracted by placing a tube in the stomach and giving intravenous medication to block the formation of acid. This is not something we would normally do laparoscopically. We also see breathing difficulties and increased stress on the heart. And the reason we're seeing the breathing difficulties is that the abdominal contents are pushed hard up against the diaphragm. The patients at this point are being ventilated by a machine, and the machine needs to use an increased ventilation pressure due to this restriction. This causes a retention of carbon dioxide, which further exacerbates the problems with raising intracranial pressure through a mechanism of dilating blood vessels. From a cardiac point of view, there's a raised mean arterial pressure, which can cause problems, especially if there are undiagnosed cardiac issues. On the legs, we have seen femoral nerve being stretched because of the abnormal position the legs are required to be placed in, as the legs have to be lowered down in stirrups to place the robotic arms. There are also reports in Australia of people losing the lower limb from poor circulation over an extended period of time. Once the table is then returned to a normal flat position, the leg has been starved of oxygen for too long. So in conclusion, less Trendelenburg is certainly easier on the patient, and this is only achieved in a laparoscopic operation. The steep Trendelenburg causes problems requiring anaesthetic changes at least, and this may account for the longer hospital stay that we've seen in robotics in Western Australia, which on average is 2.5 days in comparison to the overnight stay for laparoscopic surgery. Certainly as proficiency progresses and shorter cases ensue, then this will limit the problems with the steep Trendelenburg position. The complications, well, most of the risks and complications are identical between the two procedures, as you might expect, as the operations are the same. However, the lack of feel and feedback does become more important when we're looking at the plane between the rectum and the prostate. And if this is a very poor tissue plane, this can increase the risk of rectal injuries. This is because blunt dissection is not possible when the tissue planes are stuck. As we described, you cannot feel how hard you are pushing and therefore have to rely on diathermy and sharp dissection. In terms of outcomes, the positive surgical margin rates or measure of cancer resection appear to be the same. These are surgeon dependent rather than technique dependent, and are good for both operations for T2 disease. The positive surgical margin rates tend to trend higher for robotic-assisted laparoscopic radical prostatectomy, and this is in the higher risk disease, such as T3 or high-grade disease. Now in Western Australia at the moment, most of the disease that we diagnose and operate on is high risk. The blood loss between the two operations would be the same, as would be the erectile function and continence in the hands of equally experienced surgeons. And this is a table from a study just demonstrating the increased rate of positive surgical margins in high-risk patients with the robotic approach. So what about cost? When we introduce this machine into the operation, it comes with a cost. And part of that cost is the use of the machine, and part of the cost is the use of the disposables. So we looked at the figures based on a self-funded patient presenting to either of the two main hospitals, one with a laparoscopic approach and the other with a robotic approach. There is no equipment fee per se for laparoscopic surgery, whereas the patient at the time of this study was paying $7,500 out of pocket for a robotic procedure. The theatre fee associated with the laparoscopic operation was around $2,000, and that with robotic at $7,284. Bed fee based on one night was $950 for a lap and $2,455 for a robotic procedure. This gives us a difference of approximately $14,000 between the two identical operations. You need to ask whether this is really an issue. Certainly, if patients are happy to pay for that difference, then there are many people for whom this is not too much of an expense, considering that this is a cancer and an important problem to be fixed. Well, what tends to occur is there are a lot of patients who can't afford this, and that will restrict the pool of patients who will have this operation, and therefore that restricts the experience and frequency of the surgeons performing the procedure, which affects the learning curve and therefore the results. So cost does become an issue for all patients, not just the ones who can afford it. You need to remember that with a robotic operation, the experience and practice is only ever achieved in theatre. It cannot be achieved in a lab or practicing with a suturing material at home. So the conclusions are there are many pluses to a robotic assisted laparoscopic radical prostatectomy, and certainly if you do not have laparoscopic skills, the improved dexterity, better ergonomics and good camera control are very helpful. The marketing appeal of the machine is helpful in terms of generating cases, which is essential to become proficient. These I would all see as benefits to the surgeon rather than to the patient. There are also many negatives to introducing a robot to this equation. You've already seen the significant risks associated with the Trendelenburg position, the poorer vision, and the substantially increased costs. There is a longer length of stay currently, but most importantly, there's no actual benefit in introducing the robot into the procedure for the patient. The benefit all appears to be to help a surgeon perform minimally invasive surgery when they don't have the prerequisite training or skills to perform laparoscopic surgery. So how do you choose? Well, the results are what counts, and it's really important as a patient to try and decide based on the results. And therefore, I think that if someone can do a good robotic procedure or a good open procedure or a good lap procedure, then they're all valid surgical choices. And there's certainly good experienced surgeons who are capable of offering those operations. In my hands, I've not found any benefit from using a mechanical interface for keyhole surgery, and I find that that lack of feel, the poorer vision, and the increased head-down positions are significant negatives to the robotic-assisted surgery, and this is why I no longer perform that procedure.